think you could pass the link to anyone that you know that you think that may benefit from this.
Okay.
Yeah. So I think I'm just going to start now. So hello, everyone, and welcome to Ibi Speaks. I'm your host, Ibinabo and Enebi. Now, do you know that African and Afro-Caribbean women face a significantly higher risk of developing dementia? Today on Ibi Speaks, we shall continue our love and relationship series as we talk about as you love yourselves, as you love others, don't forget to love yourself. A dementia wake-up call for all women. And to do justice to this conversation is my special guest all the way from the United Kingdom, Dr. Moni Gasper, a dementia specialist. Welcome to Ibi Speaks.
Thank you very much, Ibinabo. It's very kind of you to have me. Thank you. Good evening.
Perfect. On Instagram and on Facebook and on LinkedIn, I read a lot about what you write about your patients. As a matter of fact, there was something I read today. Was it today or yesterday when you talked about an elderly couple coming in?
My star patients.
Yeah, your star patients, yeah. And you talked about how the man deliberately was caring for his wife, even when sometimes she felt that the care wasn't necessary. And I really loved it.
Yes, I have a star patient that really moves me. And I love all my patients, but I love the elderly best. And this week was this elderly Asian couple. I think the lady is 88 and her husband is 86 or thereabouts. And it was just so sweet to see how he looked after her for all her problems when they come into surgery. And what they came for was totally unrelated to what they went out with. And it was just about them being heard, and more so the caregiver, who's the husband, than the wife. And we went through our consultation together, but at the end of the day, I was providing more support for him than I was for his wife, which is always so sweet to watch how they navigate the terrain of older age and dementia care.
Fantastic. And there's something else that you wrote that I read. You talked about attending an event, and I wrote it down. I quoted it again back to you, and you said sometimes your presence is more important than your present.
Yes, in dementia care, which is primarily what we're talking about, we need to meet our patients, our loved ones, our friends where they are, rather than try to drag them into our reality. And so I think it was the Cannes event that happened last weekend, and I was absolutely exhausted that day. But I just knew that I had to attend because of what Cannes means to me and how much they support elderly care and people living with dementia. And at the end of the day, it was really about celebrating colleagues in that space, but also about highlighting the people in our community, the Black African Caribbean community, who live with dementia. And you're not doing it for others, you're doing it for yourself, being present where you need to be to raise the profile of these people that live with dementia and their caregivers.
Fantastic. So this conversation is part of my love and relationship series. I've been doing, I've had almost 6-7 episodes, and I think you reached out to me and we had a conversation about the way that our cultural patterns of care puts African and Afro-Caribbean women at a higher risk of suffering from this disease. And so I want to start by asking you this question, that why are we Black women more susceptible to this condition?
Okay, I'll start with, just a general overview of what dementia is. If you think of dementia as
Okay.
a term, and there's more than 200 types of dementia. In our community, the commonest form of dementia is vascular dementia, which is associated with high blood pressure and diabetes. But overall, Alzheimer's dementia is the commonest dementia globally. The numbers are skyrocketing, and by 2050, the WHO is reckoning that Africa, the African continent, and the African diaspora will make up the majority of people with dementia. And we know that most of the people living with dementia happen to be females. There's lots of reasons why dementia happens in the first place. Genetics plays a part. There's genes that put you at higher risk of getting dementia. But we also know that your genes might load the gun, but it's your environment that pulls the trigger. So what that means is that where you live, how you live, who you live with is more important than the genes that you've inherited from your parents. Why women are more susceptible, there's so many theories about it, from could it be due to hormonal changes as we age? That's a possibility. Could it be due to traumas that women who are more vulnerable globally than the men? Could it be due to that? That's a theory as well. Could it be due to factors that we haven't quite yet identified? There's a lot of research that is going on to the specific reasons why women are more susceptible. But if we come home to our African Caribbean women who end up developing dementia, a lot of it tends to come from a combination of Alzheimer's disease and vascular dementia. When you hear vascular, always think about diabetes and hypertension. Always just have that in the back of your mind. So you want to ask, why are we getting more of that? And the work I'm doing now is looking at how trauma affects Black women and how that is a risk factor to us developing dementia. And there's a lot of research that is already ongoing, but most of the research is in the Caucasian population. So we need a lot more within our community. When you think about trauma, think about big traumas like war, like poverty, like armed robbery, things like that. Those are big traumas that once you think about it, you know that that is very traumatic for anybody. But also, when you think about trauma, the lesser traumas that nobody speaks about is traumas that you can call them little t's or micro traumas or invisible traumas. And childhood traumas, racialized traumas for people who live in the diaspora, migration stress, domestic abuse, all of that is trauma. And the body keeps the score. That we know as well from a lot of research. And it's those traumas that get handed down from generation to generation. And that is where we need to say it ends with me. It needs to stop.
Fantastic. So we've talked about, there's something you've said that I don't know how to explain it. You said our genes play an important role, but the environment where we find ourselves is actually what pulls the trigger. So environment then is a crucial part in this ailment, as it were.
Yep, 100%.
Okay. So whenever I hear about dementia, I get confused between dementia and Alzheimer's. So what's the difference then between dementia and Alzheimer's?
Okay, thanks for that. Dementia, like I said, is the umbrella term. So like think about having a fever. If you have a fever, you could have a fever with an ear infection. You could have a fever if you've got flu. You could have a fever with tonsillitis. You could have a fever if you have an infection in your urinary tract. So fever and dementia are umbrella terms. Alzheimer's is a type of dementia, and it's named Alzheimer's by the person who first discovered it in the 1850s, Alois Alzheimer, a German neurologist. So it's named after him. So Alzheimer's at the moment is the commonest type of dementia, but in our community, vascular dementia is more common. Alzheimer's is very common, but vascular dementia is more common in our community. So it's just one of the 200 odd different types of dementia. You can get dementia from lots of different illnesses, not necessarily just from Alzheimer's.
Fantastic. And so what are some of the most common? So we're going to look at two things. What are the most common and what are the most hidden symptoms of dementia?
Dementia has loads of symptoms, and that's why we need to talk about it. Loads and loads of symptoms. You can meet two people and they have completely different symptoms. I'll just focus on the earliest symptoms that people can have when they're developing dementia, and that's apathy. Apathy is a lack of interest, a lack of joy. They're not in things that they would normally, you would invite me out, oh, let's go to this party, and say, oh, I can't be bothered. I look well, I'm going to work, I'm carrying out all my household chores, but everything is an effort. That is the first sign very often missed of dementia. And sadly, in our community, most people, by the time you get referred to the memory clinic, it's already in the advanced stages, because dementia starts, by the time symptoms show to when it first started, is about a 20-year lag.
Really?
So community, we're having people in their 30s, in their 40s, in their 50s, who are showing signs of dementia because they have high blood pressure or they have diabetes, or they may not even have any of those diseases. And they're already showing changes, but rather than go and explain to the doctor something is not right, the family brush it off and say, oh, you know how she is, that's how she is, just ignore her. But there's something wrong and it needs to be checked out, it needs to be addressed. Because if it's caught at the early stages, you can live very well with dementia. And most times it's caught in the more severe later stages, which unfortunately, it's a question of just managing the symptoms and supporting the person as best as possible.
Okay, so apart from apathy, what else? Is it the forgetfulness? Is it what else? Because I don't know.
Apathy is just one of the early symptoms, but everybody presents differently. I wouldn't be able to tell you what symptom you has. You would be telling me, Mommy is not the same. You might not be able to put your finger on it. You might not be able to identify it. Sometimes you might think it's depression. Sometimes people just say, oh, it's old age. You know, everything is attributed to old age. Even when you're 50, it's old age. You know, so it's the people who love these people can say there's something different, but I don't know what it is. And that's when you have to go to see your doctor, and then investigations can start. What is happening? I have a lot of patients who have dementia, and you look at them and they look no different from you and I. They're managing their lives as best as they can. I spoke to an elderly gentleman last week, and he knows he has dementia. He knows his wife has dementia. They both have Alzheimer's, and they know they forget to eat. So what did they do? Because they know they have dementia and they've had it for quite a while, they've employed a chef who cooks for them twice a day, 5 days a week. So at least they make sure that bit is covered, rather than asking each other, have we eaten? And the wife can't remember, the husband can't remember, and maybe they've eaten, but they don't know how much they've eaten. But because they knew that they had dementia from a lot earlier, they're able to put measures in place to support themselves. so that they don't suffer too much of the consequences of having this brain disease. It's a neurological disease.
Okay. Now, how can women, as it were, because we, some of the patterns, I was reading something that you wrote, and I think you said that it is our cultural patterns, the demands that we place on ourselves and culture plays on ourselves, or rather the demands that we place on ourselves and culture on us that push women to the edge.
It's a very big, wide spectrum. And for African Caribbean women, we're naturally caregivers. We've been socialized that way, and that's all we've ever known. Our mothers provided care, our grandmothers provided care. And if you go back to what I said about big traumas and little traumas, they're woven little traumas or invisible traumas. Think about neglect, think about gaslighting, think about emotional suppression in long-term relationships. All these contribute to pressure and rewiring of our brain networks, and especially the emotional suppression. So now you don't ask what is wrong with you. What you should be asking is what happened to you. And there's a lot of work that's being done all over the world on this. Not all trauma is loud. Some of the most damaging kinds of trauma are quietly normalized, but you find that it's our fellow sisters, aunties, friends that silence us or gag us not to speak out about the traumas that we're suffering as African Caribbean women. Remember that your genes might predispose you to certain conditions, but it doesn't mean you're going to develop those conditions. And a lot of people may not even have the genes that put them at risk of dementia and other illnesses, but being in a toxic environment or being in an environment that silences you and you cannot speak, you're almost a living robot. That will rewire your brain and predispose you. And what I'm also looking at, the silence that carried on for the first 50, 60, 70 years, it's like a ball of wool. Once dementia sets in, everything starts unraveling. And the person that was the perfect lady, the pillar of society in church, in the community, now starts blabbing out whatever comes to mind, or she sees you and your hair's beautiful, Ibinabo, but she will make a comment and it's like, oops, what's going on here? And that is the unraveling happening bit by bit. But if we support our women from a very young age, because we're all socialized in that way, this isn't something that started when you turned 50. This is something that has been right from the beginning. So we have to start socializing our daughters and our sons and our granddaughters and great-granddaughters to learn to speak up for themselves, not being rude or anything, but if you don't like something, be confident, and your environment needs to support you to speak up about things that are not serving you, because the body will always keep the score.
The body will always keep the score. So to all of us who are tuned in today, you can be a part of this conversation by writing out your questions so that Dr. Moni can answer the questions for you. We are socialized in a certain way. Learn to speak up for yourself. Otherwise, the body would keep the score. Okay, so there are so many questions I want to ask, but it appears that you've answered most of those questions. Now, we've talked about the early signs. We've talked about the fact that the most common type of dementia that affect us as African women is the vascular dementia, because it kind of like feeds on those conditions that were most predisposed to, which is diabetes and high blood pressure and all of those stuff. So I want us to talk about how then we can support family members with the condition.
Accept is what it is. You know, there's not much to say about it. Because when somebody has been diagnosed with dementia, bear in mind that the biological changes in the brain have started 20 years prior. So we've kind of missed the boat in terms of trying to change anything going on. It's what it is. This is where we are. What do we do? But with dementia, even though memory is dipping or they're losing memory, usually short-term memory, emotions remain intact. The part of the brain that codes emotion, that takes a lot longer. That's almost at the terminal stage before that starts going. So they may not remember what happened or where they went, but they remember how it made them feel. So you must always meet people with dementia where they are, rather than trying to bring them into what you think is, this is where they should be. And if they say the sun is shining at 12 midnight, you say, oh, yes, that's interesting. Accept it. Don't argue with them. Because when you argue with them, it increases the confusion. They get very upset, and the cruel part of the disease is the confusion it causes in their minds. And when they get very confused, that's when they withdraw and they don't want to interact with society at all, and everything just starts going downhill from there. You know, so always agree with them. Never argue that, no, you don't know what you're talking about, or no, that's not true. Oh, can't you remember you've just eaten 2 hours ago? I haven't eaten, nobody has given me food. Oh, would you like something else? If you know they've eaten, give them fruit, because you don't want to make them start getting big or anything like that. Give them a piece of fruit or give them a drink. Distract them in one way or the other. Don't disagree with them and don't challenge them, because that is their reality.
So I'm just looking back in retrospect. So does it mean that some of the difficult behaviors that we experience with our elderly relatives or parents could be dementia and not just being difficult? You know, sometimes people will say, my God, old people can be so difficult. So sometimes it is not difficulty, it is the disease.
Yeah, old people can be difficult, but young people can be difficult as well. Everybody can be difficult. I can be difficult if I want to be. I'm sure you can be difficult as well if you want to be.
Oh, very difficult.
And old people can be difficult, but a lot of times that old people are being referred to as being difficult, their needs are not being met.
Aha.
The only way they know to express themselves. They're not being difficult because they choose to be difficult. They might be hungry. They might want to use the bathroom, but they don't even know how to tell you, I need to use the bathroom. They might not like what you've put on them. You might have had this fashionista all her life, and now you're just putting any frumpy outfit on her and expecting her just to be functional, clean, and, you know, what's the problem? No, they treat them exactly how they were, which is why it's so important for early diagnosis and to know the individual patients. If it's somebody who likes to do her hair, to wear her lipstick, do her hair, wear her lipstick, spray her perfume, whatever she likes to do. She's human. She might have a disease, but it doesn't make her any less human or him. And also with a lot of people who are being difficult, as a lot of people say, it's reliving the trauma that they've experienced in their earlier years. So certain tones of voice is a trigger for them, and then they start being difficult. Maybe they've gone through, which is where caregivers really, really need a lot of support, because caregivers are the ones who see these behaviors that they don't even understand where it's coming from. You don't know where that man or woman, you don't know what has happened to them in their lives. And you need to know that to be able to put their behavior in context.
Okay, so this is what I'm going to do. I have a few questions here from some of our listeners. So I'm going to read this question out for you. It says, when there has been a trauma, you have only just been able to understand was trauma. What can you do to help yourself start to unravel the wool?
You first have to acknowledge it. Instead of what's wrong with you, it's what happened to you. But our culture, we have lots of beautiful parts of our culture. Don't get me wrong, I love our culture, but we have a lot of toxic parts of our culture that we need to call out. We cannot afford to keep silent for everything in the name of culture and in the name of respect. We need to call out things that happen as they happen. But there's the shame, there's the stigma, and nobody wants to feel isolated. You know, we're social human beings. So a lot of people, especially women, just to be able to fit into the society they belong, they keep silent and they just swallow all these traumas. So we need to support people to speak their truth and actually believe them. There's a lot of trauma-informed specialists out there. I'm not a trauma-informed specialist, so I'm not going to speak on it, but you need to acknowledge that this is what is happening and call it out for what it is in a sensitive way to educate us, not to shame anybody or disrespect anybody.
Wow. Before this program, I had a conversation with one of my daughters, and she was telling me that our culture has this habit of shaming people for speaking the truth, that everything, that as a young person, you cannot call an adult out that has mistreated you. Everything is cloaked under disrespect. So they are being trained to just shut up. Whereas the younger generation say, no, you can't do that. The younger generation tend to speak out, and then they are labeled as rude. So what you've just said resonates. What she said to me today resonates with what you're saying, that rather than allow them to burst, rather than allow our younger generation or our girls to internalize things that they feel is not right, all in the name of respect, they should be allowed to speak their minds, because it is a healing process, and it's like a preventive care against dementia. Is that what you're saying?
Absolutely what I'm saying, and your daughter is very intelligent and she's 100% correct. I agree with her completely. And the earlier you let her hear her voice and have her voice heard, the better she will be a better adult later on, a better sibling and a better daughter to you. And if she's not able to speak out, what will happen is she will internalize it. There will be a lot of anxiety and she will not trust herself, because she has learned that she cannot trust herself, because every time she said something, mommy would say, shut up. So you have them say what they want to say, even if you want to bite your tongue and you want to explain to them, if you say it this way, but if they're speaking the truth and they're genuinely asking questions that they don't understand, then it's your duty to listen and to guide them and encourage them. And those are parts of our culture that not all families do it, Some families, you would wonder if you belong to the same culture because they're quite open and they allow open conversations. But some families I know, you dare not even raise certain conversations, which is very unhealthy.
Fantastic. So I'm just going to, again, I'm just going to say that this conversation is for all of us. So if you have any questions or comments, kindly leave those questions or comments on the comment section, and Dr. Monia would be able to answer those questions for you. And someone talks about intergenerational trauma. Someone just talked about intergenerational trauma. And does that also trigger dementia generationally?
Yes, because if my mother or my grandmother or my great-grandmother has gone through trauma, civil war, abuse, neglect, emotional suppression, poverty, all the little T's. Remember, T's and the little T's. If they've gone through all of that and they haven't been able to address it formally or informally, then they're holding it within them. That changes their neural wiring, their brain networks, and that is handed over epigenetically to the next generation.
Fantastic. So, are there lifestyle choices that women make today that increases the risk of the condition?
There's loads of lifestyle choices. Think of the food we eat.
Okay.
The food we eat might be very healthy, but quantities are not always very healthy.
Okay.
You go to somebody's house and they feel they need to give you a massive bowl of food, because if they don't, they haven't welcomed you properly. And they also expect the same when they come to your house. So you might want to offer them a plate of fruit or salad or something small.
Something light.
Something light.
Yeah.
The attitude is you didn't want them to come to your house. And that's a very big cultural thing. So that's one aspect of it. Exercise is so important. We can spend a whole day discussing exercise. But in certain circumstances, especially at certain ages, it's not frowned upon, but it's silently discouraged.
To exercise?
You want to go out for a walk in the evening. It's expected that your spouse or your partner has to go with you. I've heard comments like, you don't know you're a married woman now. Or you're size 10 and you think, oh gosh, I've put on weight, I need to cut down. And you get comments like, you've just had a baby, or you don't know you're a married woman. And all of us are relational human beings. You want to be accepted in your society. So you want to be like the people around. You don't want to be different. It's normal to feel that way. So then you give, okay, I'll leave size 10 and become size 12. And from there, you'll get to 14 and 16. And before you know it, you're obese. And then the high blood pressure sets in and the diabetes sets in and all other complications, aches and pains all over. So there's lots of different aspects of it. Nutrition is a big one. Lifestyle is a big one. Sleep is a very big one. A lot of cultural expectation that you have to do everything in the home. You have to keep doing, even if it encroaches into your sleep. To do is done. But no, you need to sleep, because it's only when you're asleep that your brain rests. So you can't survive on 5 hours or 4 hours.
Oh my gosh. Okay.
Used to do anyway.
Wow. Again, please keep the questions coming. Dr. Maria, I have somebody who has asked to want to speak after you've spoken. So, Caroline I would let you speak after Dr. Amania has spoken. So, from your experience, how does dementia uniquely impact women, both as patients and as caregivers?
99% of caregivers are females.
Okay.
That's probably from our social background, our culture. Caregiving is not all bad. I know it's portrayed negatively in a lot of ways, but it also has a lot of positives. It can provide a sense of purpose. It feels like giving back, especially when you're caregiving for a loved one. But it's a lot of reluctant caregivers who absolutely are not happy with who they're providing care to, but feel they have no choice, that they have to do it. And how it impacts is lots of different ways. There's a physical impact if you're having to provide physical care, as in personal care, to somebody who might be the same size as you. I'm 5'2". Imagine if I have to provide care to somebody who's 5'9" or 10 or 6 foot. You know, we'll be falling all over the place if that were the case. So physically, there's that strain. You see a lot of caregivers, and now we ask in consultation, when you see middle-aged women, especially coming in with shoulder pains or back pains, are you a caregiver? Because they weren't necessarily offered that information. And you hear things like, oh, I was helping my husband to get out of the chair, or I was helping so and so to have a wash, that kind. So there's the physical impact, there's the psychological impact and the mental impact. If you're caregiving, you're working full time, you have young children, sadly, there's young onset dementia, and that's dementia tends to happen before the age of 60. So when that's happening, very likely both parties are still in full-time employment and you're still having to provide care for somebody. It's a very difficult and a very sad circumstance and situation for those people. But they want to do it because of the love that they have for the person they're caring for. And they need support for that as well. You even have children who are caregivers. And now schools are recognizing that when a child is coming to school and falling asleep, it's not because they're watching television. They might actually be caregivers for their parents or their grandparents, because there's nobody else that can do it. So it's them asking the question in an open way and hearing what they're telling you in a, don't be judgmental or, look down on them or sort of make fun of them or express shock at how is that possible. But actually hearing what they're saying and looking for solutions and offering support for them.
Fantastic. And you talked about reluctant caregivers. So what are some of the practical ways in which somebody who is a reluctant and willing caregiver, what are the practical ways in which they can prioritize the mental and emotional health?
It's very tricky. There's no easy way about it. They need to be given the space to be able to speak about their experiences. There's lots of written material that can support them. They need to also have time for themselves. Every caregiver needs to have time to do what they like to do. You cannot care 24/7, even for your own child that you love more than anything else in the world. You need a break. And if somebody is a reluctant caregiver, very sadly, I recently met a lady who was in her 70s, and she was a typical reluctant caregiver. And the first time I saw her, she just cried and cried and cried. And then she came back at another time, and all she said is, I'm divorcing him. And I was coming from a traditional background. My first instinct was, oh my God, what's going on? And then later on, I thought about it, and I thought this was the height of self-preservation. She knew she couldn't do it, because with reluctant caregiving, then you have the risk of elder abuse. So it's not a straightforward thing at all. And they need.
Hello? Have I lost you? Can you hear me?
Yeah, I can hear you.
Okay, I lost you for a few minutes.
Sorry. Can you hear me now?
Yes. Okay, continue.
Yeah, no, so I mean, it's not a very nice thing to see or to watch, but that is the reality for some people.
So the reason why we have the elder abuse is as a result of the reluctant caregiving.
It's not the only reason, but elder abuse is very common with reluctant caregivers. That's not the only reason for elder abuse. There's loads of reasons for elder abuse, even from family members. There's financial abuse, there's physical abuse, there's emotional abuse, there's loads of aspects of elder abuse. But if you're doing something that you don't want to do, then you're less likely to take care with what you're doing.
Fantastic. So are there any cultural stigmas around dementia you've observed in the African and migrant communities, and how do you want to address it?
It's as simple as that. We don't do dementia. It's old age.
It's old age.
For us to change that mindset. Dementia is a neurological disease. Nobody wishes for it. Nobody prays for it. But if it happens, we have to accept it and provide the support that we would provide to cancer patients, to hypertensive patients, to diabetic patients. It is a disease. To patients with Parkinson's disease. Parkinson's disease is another condition that's very strongly associated with one of the types of dementia. But people pay attention to the Parkinson's and relegates the dementia to the background. We need to change that narrative.
So we don't talk about dementia in our culture. It's old age. And how, so you've said we need to change the narrative. How do we change the narrative? Like, it is a taboo for me, for example, to go to a friend's house or I'm in a public space and I say, oh, my grandmother had dementia or my father had dementia. We whisper it. How do we change it?
By having conversations. It's a process. It's not going to change overnight. It's not going to change tomorrow morning. But the more we talk about it and the more we stop hiding people who are living with dementia. They might wear a green top and blue trousers with orange earrings or, whatever that might not seem appropriate. Or they decide that they want to wear their shirt inside out. That's fine. We just need to normalize them in our society. They are human beings and they are our loved ones, our mothers, our fathers, our brothers, our sisters. And who knows what's coming ahead? None of us do.
Okay, now I'm going to ask you another question, but we're not segueing, we're just going to dig deeper into that. So how then can we raise more awareness about dementia in the underrepresented communities? I know we have to talk about it, but what more than talk, what else can we do? How do we create the awareness? Like, we go to church all the time. So do we have more church programs addressing the situation? Do we just talk? Do we have more programs like this? Do we go on social media just the way you do and then talking about your experience about it? What do we do?
Talking, but for me personally, I think dementia awareness has to start from childhood.
Okay.
Good dementia, but that's another conversation. So we won't go into that right now. But it has to start from schools. We need to talk about brain health right from the beginning. I'm driving home from work at 2 o'clock sometimes, and I see children walking back from school. Before they get home, they're carrying McDonald's and chicken cottage and all sorts. I remember, I'll tell you quickly, my son came home when he was little. He's grown up now, and he had chicken cottage. And I'm like, where did you get the money, first of all, before we start talking about why are you eating junk? And he said, oh, the man gave it to me. And I was like, oh my God, which man gave it to you? I said, take me to the man who gave it to you. So he took me to Chicken Cottage. And the man said, yes, that the children come by every day. And if they don't pay on that day, he knows they'll bring the money. So junk food is out there and it's so open to the children. So I had to sit him down and explain to him about the pros and cons of eating a healthy diet and how it affects your body and all of that sort of thing. But if that hadn't happened, I wouldn't have known how perverse junk food was. Because you think you've cooked at home, so they're going to come home and eat. You don't between they leave school and they get home. Even if they eat at home, they've probably had a packet of McDonald's on the way.
So junk food is perverse. Hey, Lord. Okay, so what I'm going to do is, and thank you very much, my special audience, keep the questions coming. Doctor, I'm just going to read some comments over here and some comments and some questions as well. And somebody talks about educational awareness, which is important. And someone says, don't know if you've asked about it already, but let me ask, how can and what can younger people do to ensure that they don't get dementia later in life?
We've talked about it a little bit, but there's absolutely no harm going over your nutrition, your diet. But even before you get to that stage where you're in control of your nutrition and diet, it's how your parents raise you, how much you're heard in the home. Our traditional background is you're seen, you're not heard. Just do what you're told. I don't want to wear this top today, I want to wear the other top. It might not be a big deal, but are you the parent who insists you will wear what I tell you to wear? You're taking away that child's agency. And those are all the things. One episode is not a problem, but when it happens continuously, you're slowly eroding that child's confidence. You're laying the foundation for future anxiety. And it might seem something very simple. I've seen families where you just go into the kitchen and you bring out what you want for dinner and you have to eat this. What if the child doesn't want that? I'm not saying give them everything they want, and I'm not saying don't discipline your children, absolutely not. But you need to have conversations with your children.
Okay. It's a lot. I'm just thinking back and just remembering the way we were brought up when we were little and how our children are demanding something better, demanding to be heard, speaking their minds.
Good for them. Well done to them.
Okay. So somebody asked here, can it be cured? And I mean, is it curable?
Right now, sadly, there is no cure for dementia.
Okay.
There's medication now, new biologic medications that don't cure dementia, but it slows the progression. However, it's only used in early stages of dementia. Majority of the African Caribbean population are diagnosed in the more advanced stages.
Wow. I'm trying to get my YouTube. Okay. Now so just not to sound a bit confused, what are some of the most advanced stages of dementia? Because you said it presents itself differently, but there must be something that that I would have to see to say, or let me put it this way, what are some of the most common threads of dementia that happens across the board, that no matter what, I know that this is dementia?
There isn't one single thing that you can see and say, this is dementia. Majority of the severe terminal cases, you will not see them in public. They will either be in a care facility or in a home with 24-hour wraparound palliative care. So you will not see them unless it's somebody who's in your family that you see. Some extreme dementia cases can appear moribund, like somebody who's dead. Don't forget the brain cells, the brain starts shrinking. So you might find a brain that's like this at the beginning, and then gradually it all becomes mush at the end of, and at that time, they're unable to do anything for themselves. And I don't expect them to be visible publicly unless it's your loved one and you go to see them. The earlier stages, you have behavioral changes, you have, depressive kind of symptoms, which you have to figure out what's going on. What people see commonly is repetition, being asked the same question 100 times. Is your mummy? And then 5 minutes later, how is your mummy? And 5 minutes later, how is your mummy? And they don't know they're doing it because they don't remember that they've asked that question. So that's what most people would tend to see. And in the earlier stages, you might just notice, a little bit of apathy or somebody not taking care of themselves as they used to. Somebody who doesn't want to brush their teeth or, start having hallucinations in the sense that they start seeing invisible people in their space, children, adults, or talking to invisible people, sometimes in a friendly way. They're laughing and playing with invisible people. Sometimes they get really agitated about these invisible people and then they start lashing out and cussing and that kind of thing. So every case, which is why it's so important to understand where this person is coming from. Because if you know their background, it puts into context what you're seeing. Otherwise, you're just seeing bizarre sort of behavior.
Okay. Now I'm going to read the comments I have here. Thank you. Let me read out these comments. Why do some people suffering from dementia recognize certain people and not others? Like a man who has dementia recognizes his son's friend, but not his son.
It depends on what kind of dementia you have. And also it depends on the part of the brain that's affected. All our executive functioning happens in our frontal and prefrontal cortex, which is like, think about how you read, how you study, how you learn things. All of that happens in the front part of the brain. In diseases, that memory loss is a very common feature. What is happening is that they're not registering those events or those meetings. So what then happens is they might meet you today and tomorrow morning they say, I haven't seen you for weeks or months or years, but they'll remember something that happened 50 years ago. Because all their short-term memory has not registered. So they can't bring it out of their memory bag, but they will remember past events. And it just slowly progresses. And eventually, bit by bit, depending on what time you came into their life and the impact you made on their life at that time, whether they remember you or not, whether your presence is associated with good emotions or negative emotions. And it just keeps going back until you start finding they'll possibly start asking about their mother or their father who may have died 100 years ago, because they're almost at baby stage at that.
That's far back.
Yes.
Yeah. Okay.
About food, they can't remember that they've just had breakfast.
Wow. Somebody says long-term and short-term memory, long-term memory is much stronger than short-term memory. Okay. Is dementia, is it hereditary?
There's certain communities in South America that have are being really studied intensively because they have people in that community who have early onset dementia. That's before the age of 60. And it's almost a given that everybody in that community will develop dementia. So they're being studied, but dementia is not necessarily hereditary. You might have the ApoE4 gene, but it doesn't mean that you'll go on to get dementia. And some people who don't have the gene go on to get dementia. So no, it's not hereditary in that sense. But again, don't forget there's different kinds of dementia. So some of them are more genetically linked than others.
Fantastic. So I just want to say that if you're joined us today for the first time, my name is Ibinabo Enebi, and I'm the host of this podcast, Ibi Speaks. You can follow me on my social media handles, Ibinabo Enebi, on LinkedIn, Instagram, and Facebook, TikTok as well. And you can also help this channel grow by subscribing to my YouTube channel, Ibinabo Enebi. I have very interesting episodes. I have the podcast on the love and relationship series. I have a broad spectrum conversations that I've had, including the Jackpa series, which I really, really like. Okay, so what role can faith and community play in supporting women affected by this condition?
A lot, but when it's a positive faith experience.
Okay.
And when it's
positive
experience, because a lot of African Caribbean people are socialized to be silent. So they don't necessarily speak what they're thinking, or they don't necessarily speak what is actually going on, what they're experiencing. And you will find that a lot of the behavioral and psychological symptoms of dementia is actually unresolved trauma that has happened previously in their previous lives. But a very supportive, warm faith community can help a lot with people living with dementia and their caregivers, because of the positive emotions that it provides for them.
Wow. Okay, so at this point, I am going to leave the channel open. And if you have any questions for Dr. Ammonia, I'd like you to kindly raise up your hands, and then I would call you. And I want you to be aware that this program is streaming live on Facebook and on my YouTube channel, Ibinabo Enebi. So if you feel comfortable speaking, that is fine. Otherwise, you can write out your questions in the comment box and I would read it out without mentioning your name, if that's okay with you. So if you want to speak, kindly raise up your hands with the icon.
Hi. Unfortunately, my hand icon is not working at the moment, so my apologies for that.
Perfect.
I was the one who asked to make a comment. And thank you guys for this opportunity, and thank you so much for highlighting this within the community, Afro-Caribbean community. I have a very strong devotion for people with dementia and dementia because it's dear to my heart. My mother had dementia. And as the doctor spoke about the different types, she had vascular dementia, which was one of the most common. And I am a nurse for people with disabilities. So I found myself in an area where I do care for a lot of people with disabilities, mostly people with Down syndrome, because they have the lack of the trisomy 21. So they end up getting dementia much, much earlier than the normal public. And also with that, I found that I had to be the one to take care of the education for my family because they couldn't understand what was happening to mom. And a few years later, we found out every single person on my mom's side of the family had precursors of dementia and dementia. So they all passed off with dementia. So one thing I want people to understand that dementia can show up in many ways, as the doctor did say, and high cholesterol is a very common one. You know, people need to take care of high cholesterol when they are diagnosed with it or if they have it. Another one is menopause. A lot of people keep saying, oh, it's my memory because I'm in menopause, but you need to get that checked. The doctor also talked about there's no cure, and there's really no cure, but there's management. There's a very common medication called Aricept. Now, Aricept is for early onset, so it won't have any effect later on if the person is diagnosed and they're gone past. The doctor can support me with this if I'm wrong. In the area of intellectual disability, we do a lot of reminiscence therapy, and reminiscence therapy is we're trying to support the care of the person by reminiscing on the very positive aspect of their lives. That if they loved reggae music, you know, if they like the smell of a certain perfume, if they like a color of a certain dress, or they used to go and play golf, could you take them for a ride to the golf club where they used to go to? You have to kind of still take care of them like they're still there, and they're still important. They're still human beings. So you have to show them that you care. Yes, there can be a sort of care burden that it can affect you psychologically, it can affect you emotionally, as the doctor said, but you can't do it on your own. So you have to make sure that you're changing faces, or one family member takes it this time, then another family member. It cannot be a burden, because when it becomes a burden, then they start to become abusive. The carer will become abusive. In Ireland a few months ago, I'm in Ireland. A few months ago, they gave us the opportunity to go on a dementia bus. I don't know if Dr. Gasper is aware of this. Now, I think every single human must go on the dementia bus, because it's an eye opener because even if you're a carer of a person with dementia, you cannot psychologically or physically understand until you are either put in that bus, and then your perception totally change. Because my perception changed so much that it made me understood why my mom stopped walking, why my patients stopped walking, why their taste buds changed, why they were not hearing me, seeing me, So I think education and awareness is one of the major key aspects of teaching our community about dementia. So thank you so much.
Fantastic. That dementia bus is interesting.
Yeah.
Is it in Limerick?
It was all over in Ireland, so it went to different places in Ireland. So care staff and the normal public could utilize it, and it should be continuous all year round, I think.
Fantastic. And doctor, do you have any response to that? Do you have anything to add to that?
Thank you for being so vulnerable. You're absolutely right about everything you've said. You can't walk in the shoes unless you have the illness, and none of us hope or pray for that. But yes, the dementia bus, it's very uncomfortable, very unnerving, very confusing. You even question your perception of your physical self. It's not nice at all. If you get an opportunity, especially if you live or you're caring with somebody living with dementia, it'd be worth going into. Yeah, people with intellectual disability tend to get dementia earlier on in their lives and have a slightly shorter lifespan, but it's known that that is what potentially can happen, and you have to accept them where they are. You have to call it what it is and support them where they are, rather than trying to force them into your space. Families might struggle, and that's the beauty of early diagnosis, because you can have conversations with the person living with dementia, and honest conversations, and they'll tell you what they want, what they like, what they would like to see happen, how they would like their care to be. And the children or the siblings that are struggling with seeing their parent or their loved one deteriorating. It's a double grief, they say, with dementia. You're grieving the person that you once knew when they're still alive. And then eventually when they pass away, then that's another grief again. But it's all about accepting what it is, preventing obviously when you can, but accepting the disease when it comes and supporting one another. You can't, the time has gone where we keep silent about it. My mum used to say something is, you can't hide what is
not hiding you. Okay, please keep the questions coming. Now, let's talk about the practical tips or the practical tools that we can use to prevent this condition.
I think we've said quite a bit about it.
Practical tools, yeah, okay.
Eat carefully, eat sensibly, eat not the other way around, and look at what it is you're eating. Living such busy lives that, you just grab what's there. That has to stop. We're in such a fast pace that nobody's sitting down to actually smell the coffee. Got takeaway mugs, you're drinking your coffee in the car at risk of spilling it on yourself. You're going into any cafe or Costa or any of those places and buying whatever you find over the counter. You don't know what's in it. Carlene is absolutely right. Know your numbers. When last did you have a routine bloods? When did you check your cholesterol? What's your good cholesterol? How much of bad cholesterol have you got? Because it's clogging up your arteries. And some of the cholesterol might not be what you're eating. It might be what you've inherited from your parents. There's familial cholesterol. So there's all of that. But if you don't go to the doctors, nobody's going to come to your house and blood test. And we're notorious for not going for our screenings, not going for routine checks. And that has to stop. We need to encourage everybody around us. When last did you have your screen? What's your last blood pressure? How much do you weigh? It sounds funny, but these are real life important questions we need to be asking ourselves.
Fantastic. So somebody raised up their hands, yeah? Okay. Okay. So again, does anyone have any questions? Somebody raised up their hand. Somebody wrote this for me. Somebody says, are there markers that tell us what stage dementia is at? Somebody's asking that question.
There's no markers that tell us what stage. That's more of a clinical diagnosis, but there are more recently blood markers that can tell if this person is at a much higher risk of developing dementia. In the UK where I am, it's not routine now, but it's in the research centers. And very soon, we hope within the next 5 years, it will be rolled out for everybody and it would help to, but what we find, which is why awareness and education is so important, all the research that's happening, if you get 10 participants, one will be an African Caribbean. We just are so reluctant, sadly. And the thing is that we're the ones that are most affected by this. So it's something that we have to really consider getting involved in research. You can volunteer to participate in research. You can come out of it at any time if it's not for you. But I would strongly encourage everyone to consider volunteering for research. A lot of the medications that are out there, we don't know what effect it will have on African Caribbeans, because we're not in the research.
Yeah, because we're always hiding. Okay, so somebody asked this question. Please share on lifestyle to correct cholesterol.
Weight-bearing exercises is the top of the list.
Weight-bearing?
Because you want to build muscle. It's not just about losing weight. So cardiovascular exercise is great, but you want to focus more on the weight-bearing exercises. You need to look at your diet, but you also need to understand that some of high cholesterol is familial. So even if you live on fresh water and fresh air, you will get it. And in that case, you will need medication. But you're not going to know if you don't have a very standard routine blood test.
A standard routine blood test,
Even
even if you live in fresh water. So cholesterol then is something that is something that there's nothing they can do about it.
in some cases, if it's the familiar type of hypercholesterolemia, which is where the high levels of fats in the blood, but it's more from a genetic perspective. Some people have that, but some people it's just diet and lifestyle that's, needs to be adjusted.
Needs to be adjusted. Okay. So I still have a few more minutes. Any more questions? This program is for you to ask Dr. Monia as many questions as you want. Okay. So yeah, I'm waiting. Okay. So how long do you need to stay on cholesterol meds, especially if your numbers have stabilized?
Your numbers may have stabilized because of the medication. So I tell my patients that your quality of life is just as important, because some cholesterol medications can give you side effects of breaking down muscle, and people complain of leg pain, cramps in their thighs and different parts of their body. If you don't have any side effects to it and you've tried different medications, if your cholesterol is stable and you say, oh, I'm tired of having to take medication every day, I don't mind if you skip your medication for a week. That's fine. Your numbers are not going to jump up suddenly because you've not had medication for a short period of time. But you have to also look, it's not just about medication. You have to look at your diet, your lifestyle. If you're a smoker, if you drink alcohol excessively, all that contributes to it. So it's not just about the medication. But if your numbers are well controlled and you're living a healthy lifestyle, if you miss a day or two, nothing is going to happen to you.
Okay. And once you start on the cholesterol medication, it's difficult to stop.
It's difficult to stop only because, in my experience, patients are, well, I'm on medication anyway, and they just let themselves go.
Oh my gosh. Any more questions? Any more questions? Keep the questions coming. So I'm going to ask you this. So what's the story with chocolate? Oh my God.
But proper chocolate, black chocolate, dark chocolate is very healthy. And in the Scandinavian countries, they use it for their maternity women. They give it to them to boost their iron levels. But that is literally like a small portion of, I don't know how much they use, but a small portion. But it's not chocolate of sitting down watching EastEnders or Coronation Street or Nollywood and just eating chocolates. And it's dark. Dark.
I can go for the dark in the bueno, dark bunty.
But chocolate is healthy. Pure chocolate is very healthy.
I have this thing I'm drinking, right? It has the polyphenol. Is it polyphenol or something? And they say it's good. I don't know if I'm pronouncing it right, but it's this berry. It's a drink, and it says it helps to reduce cholesterol. So it's a bit gunky, like the taste. It's tasteless, but I like it.
Well, enjoy.
It helps.
Joy is the beginning of good health. You have to have joy in yourself. I don't know what's in it, Ibinabo, but
I'll get it, but I'll show you.
If you're enjoying it, and also think about how much of it.
I take little. This is it. Listen, I'm not advertising anything. I went to the health shop and the guy was like, what is it called now? What did they even say? Isha has something, Sha. That is good. And I just take it. Yeah, so polyphenol, your daily polyphenol boost organic Ariona essence. But I'm not advertising anything. I just take it. Doesn't have taste, but I take it. And it's helpful. It's helped me, but you have to ask a doctor though. Okay. So this has been a very interesting conversation. And what about menopause? Because I find that, I don't know, like, I just realized that I'm having this brain fog for me personally. And after you talked about this dementia, it's scaring me.
Don't be scared. I think there's menopause experts on the forum, so I'm not going to overstep my boundaries.
So
You have a chat with your doctor. For every woman from about the age of 40, our estrogen levels start to decline. That's absolutely normal. And part of that decline of estrogen, we've got estrogen receptors in our brains as well. And so you can go through the feeling, the brain fog, and your skin can get dry and wrinkled, your hair starts falling out, and all sorts of things that come with menopause. But don't diagnose menopause when you haven't excluded other things that can be going on. If you're not sleeping well, your brain will be foggy. If you're going through stress, your brain will be foggy. And it's not menopause, neither is it dementia. And so you need to have a proper conversation with a health practitioner first. They will probably do your bloods and see and make sure that all your other parameters are within the normal range. If everything is normal and you're kind of that age where you expect to be perimenopausal or menopausal, they could attempt a trial of hormone replacement therapy. And I'm stepping into deep waters here, so I'm not going to say any more. And
hopefully we're going to have the menopause expert on Ibi Speaks.
And then, take it from there. But even if you have HRT, if it's a dementia illness, it's not going to make a difference. Those symptoms you're experiencing will still be there.
Okay. Somebody says if you experience leg cramps, should you change your cholesterol meds even if it's subsidized, even if it's subsided?
You can ask to have a blood test for your muscle enzymes, your creatine kinase. You can stop taking it temporarily if the cramps stop. And then if you start it again and you get the cramps, then likely the cramps might be as a result of the statin, which is the particular kind of medications that can cause muscle cramps. But the only way you can tell categorically is if you have a blood test and your muscle enzymes are raised, because statin medications can break down muscle.
Fantastic. And somebody says, could you please explain about is it the APOE4 gene? Is it the APOE4 gene?
APOE4 gene is one of the genetic markers. I think it's on the same chromosome. Colleen, remind me, as trisomy 21 in people who have Down syndrome. And the people with the APOE4 gene, there's APOE3 and APOE4. You can have the double gene, which just spikes your risk of getting dementia. If you've just got one of the genes, you're slightly higher risk, but it doesn't mean that you will go on to get dementia. Like I said earlier, your genes load the gun, but it's your environment that pulls the trigger. Because a lot of people who don't have the APOE3 or APOE4 gene go on to get dementia just because of lifestyle reasons.
Yeah, the reason why I asked doctor about that is because I am not sure about it. I don't know much about it, but I do believe that one of the reasons why my grandfather had it and then all his kids eventually got dementia, both male and female, is because he did carry a gene. So it's more prominent on the male side of the family. So in my family, they talk about, well, the females because my mother had it, would it also affect us because, you know, the gene was there?
What you find in families is that if you belong to the Gasper family, for instance, your life is going to be similar. You're not going to, it's rare to find one member of the family having a super healthy lifestyle and all the other members being alcoholics and heavy smokers and unhealthy eaters and not exercising. So it tends to cluster in that way, that your lifestyle in one person very likely will be your lifestyle amongst the siblings in that household. But if you have the gene, it's not 100% that you will get dementia.
Okay. So that's very interesting. That's I think that's encouraging to hear that if you have the gene, then you may not possibly have dementia. That's a very encouraging thing.
I agree, yes.
Yeah, it's very encouraging. So any more questions?
Doctor, one final question. I worked in a brain injury hospital, and I realized from my experience working there that a lot of people who got brain damage was based on alcohol, excessive alcohol consumption. Do you think alcohol also could be a precursor of dementia?
100%. And people who are heavy alcoholics for a prolonged period of time have a much higher risk of, and eventually what then happens is you don't know how much of their drinking alcohol is part of the behavioral symptoms of the dementia. But alcohol is toxic to the brain. We know that. So having excessive alcohol in large quantities over a prolonged period of time, yes, when they start, you know, even when they're not drunk, but they just sort of look in a very apathetic way, unable to care for themselves, that's not the alcohol, it's the brain changes that have happened.
Wow. Fantastic. Fantastic. I mean, I've been taking notes and notes and notes and notes and notes and notes because it's a lot to learn. And I think with this episode of Ibi Speaks, I am learning for myself. And I hope that I would make the changes that are necessary for myself as well. Thank you very much, Dr. Moni.
Thank you, Ibinabo. It's my pleasure.
Thank you so much. It's been I mean, this has been a very enlightening episode, and I am thrilled that we made it happen. So I just want to say that if you're watching me for the first time, my name is Ibinabo Enebi, and you can follow me on my social media handles, Ibinabo Enebi, on Instagram, LinkedIn, TikTok, and Facebook. And you can subscribe to my YouTube channel, Ibinabo Enebi, to help my channel grow. And somebody is saying something here. I'm just going to read the comments before we go. They say, this is, thank you. I'm just going to read the appreciation comments. So thank you very much. Very enlightening. Clap, clap, clap. That's interesting. That's interesting. One looks at drunks and blame the drink for the way they appear. Yeah. What is the acceptable dosage of alcohol for people over 45? Somebody says.
0. We've gone through so many stages. We say it's healthy, sensible limits, but the truth is that 1 unit of alcohol is toxic. So if you can avoid it completely, then that's better. But if you're unable to avoid it completely, or if you enjoy a drink now and then, it's best to spread it out over the week. So for females, I think it's 14 units that's quoted now per week, which is roughly about a glass of wine per day. But if you start and know that you won't stop at 1 glass of wine, then don't even start at all, because you'll end up having half the bottle. Yeah, so there's no safe limits now. There used to be, there's no safe limit now. For men, it's 20 units per week, spread out over the week, and binge drinking is more dangerous and more toxic. So people say, oh, I don't drink much, only at Christmas, and then at Christmas they might drink 3 bottles of whiskey. That's not good.
Fantastic. And somebody says, thank you very much for this informative session. Thank you very much, Dr. Ibinabo. Thank you very much. And again, I have more episodes of Ibi Speaks. We have more episodes on the Love and Relationship series. We're going to talk about finances. We're going to talk about recognizing the Christian narcissist. So there's a lot going to come. So if you're following me on my social media handles, then you would see when I post the ads for the program. So I'm going to have the next sessions of Ibi Speaks
on symptoms of dementia is being unable to manage finances.
Okay. So
the very early symptoms, reckless spending or not following up with bills, just caring anymore is one of the very early symptoms.
Yeah. Thank you for letting me know. Thank you. So guys, again, like I said, I have more of the conversation on love and relationship series. It's worth listening to. And if you follow me on my social media handles, I would post ads for the program and then you can join me. So thank you everyone for watching. Thank you, Dr. Monia. And thanks everyone, Dr. Monia. I'm going to call you and thank you so much. And bye, everybody. Bye.
Thank you.
I'll call you.
Okay.
Bye.